Good evening, faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar on Intrapartum Challenges in Pregnancy Delving Deeper, organized by Safe Motherhood Committee of Oxy. It's my privilege to introduce the MOC of today's webinar, Dr. Nitya Naram. Ma'am is the consultant obstetrician gynecologist at Madras Medical Mission, Chennai, and also Safe Motherhood Committee member, Oxy. I welcome you, ma'am, and I hand over the session to you.
Thank you, Sahiti. Good afternoon, one and all. Welcome you to this insightful webinar where we gather to exchange knowledge and expertise in the ever-evolving field of medicine. Let's embark on this journey of discovery together. Let's begin with the rendition of Tamil Thai Varthu, paying homage to our Tamil motherland and its cultural richness.
திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனங்கே தமிழனங்கே உன் சீரிழமை திறப்பியந்த செயல் மறந்து வாழ்த்ததுமே வாழ்த்ததுமே வாழ்த்ததுமே.
My warm welcome to Dr. Rajshri, Safe Motherhood Committee Chairperson Oxy and Executive Committee member and Senior Consultant. Ma'am, I invite her to...
Oxy prayer. Thank you, God. In humility we gather. In gratitude we pray for all the good things you have given us. Shower us with your blessings to pass on the healing touch, to celebrate the arrival of each new life and a mom reborn, the courage to deal with it all when things are not perfect, and to remember that we are but messengers to keep our women safe and free from sorrow. We bow before your kindness and the magnanimity of your endless love. Thank you. Go ahead, Nitya.
Thank you, ma'am. Now I welcome Dr. Jairani Kamaraj, ma'am, our Oxy president. She's also the treasurer at TAPISA and a senior consultant of reproductive medicine at Akash Fertility to deliver the welcome speech, guiding us through the objectives of this webinar and setting the tomorrow of a fruitful and an engaging session. Over to you, ma'am.
Thank you, Nitya. Thank you for the nice introduction. A very warm evening welcome to one and all. And it gives me great pleasure and honor to welcome you all on behalf of Oxy 23 team and the Safe Motherhood Committee headed by the dynamic Rajshri and Vasanta Mani, our committee members. And it has been a great pleasure and honor to be here to welcome the senior OGCians here from all over the world, that's in all over the globe. It's a great pleasure to welcome Dr. Lata from UK. It's very happy to see you after a long time, Lata. It's a heartfelt welcome to you to join us, to give all your knowledge and sharing your experience in this field. It's very nice of you to join with us. We welcome you. And it's a great pleasure to welcome the senior OGCians, Madam Dr. Usha Rani, Dr. Kartika Prabhu, Dr. Narmada, Dr. Nalina, Dr. Shanti, Dr. Maitrin, Dr. Padmapriya, Dr. Bhaskar, who are all here for this wonderful panel discussions on the tackling the uncommon intrapartum complications. It has been a great pleasure to have you all on this webinar. On behalf of Oxy 23, along with my secretary, Dr. Kundave, I welcome you all, both the seniors as well as the young, enthusiastic and dynamic juniors of the Oxy team, to be here on this wonderful webinar. And every month it has been a great delight to have a lot of thoughtful programs by Rajshri, taking up every aspects of pregnancy and its complications and its practical approach, which she's doing with a great commitment and great dedication. A very special thanks, Rajshri, for making a wonderful one. And without wasting much time, I would like to welcome you one and all again and wish you all a very best webinar and a very fruitful and knowledgeable knowledge that you get from this webinar. Over to the moderator MOC, Dr. Nitya. Thank you.
Thank you, ma'am. I would like to thank my entire team for helping me out every month. Thank you, ma'am. Thank you.
Thank you, ma'am. So next we're moving into the first session for today. Our next session will be on intrapartum fetal monitoring, a peep into the future. So this session will delve into the critical topic by Dr. Lata Mageshwari Palanivelu. She has worked in the NHS UK as well as worked in India. So she will be able to guide us about the intrapartum fetal monitoring in India and throughout the world. Thank you. Over to you, ma'am.
Hi. I'm sharing my screen. Can you hear me?
Yes, ma'am.
Yes, ma'am.
Yeah.
Yes.
Can you see my screen?
Yes, ma'am.
Okay. A very good evening, everyone. First of all, it's a privilege to be here. Oxy is my home. IOG is my home. Thanks for this opportunity. Thank you very much, Dr. Rajshri. My regards to Madam Jairani. My respects to her. She's my senior. Namaskaram, madam. Thanks for this opportunity. Now, I've been given 15 minutes time to talk about the intrapartum monitoring, peep into the future. I'm going to divide into two. I'm going to divide this into first part, what is actually we are practicing, a little bit about future as well. Yeah. So I'll try to do justice in 15 minutes as much as I can. Now, so we all know this is the most dangerous journey we make in our life. The baby, we think it's a trip to Ladakh, but it's not. It's the journey which we already made. And, you have every possible things that can go wrong during this journey. Contractions, compression, medications. In fact, oxytocin is one of the most dangerous, abused and used drug in our maternity wards. And it's like in every odds is against the baby in this journey. But nature is, as mother is superior. She's equipped the baby with the coping mechanism of increasing affinity, better, she can increase the heart rate is high, and there is a hemoglobin concentration is high, and so on. But the question here is, the most important thing is, every baby is different, is all our babies are equipped with is that every baby is ready for the journey is what we have to understand. And as we say, I always start when it comes to CTG, I just say it's a language. The baby is talking to us. So we have to listen to the baby. That's all is about it. And why we do it is something which I'll go through the slides a bit faster because I want to concentrate on the future part of it rather than what we are already doing. So we know, it's been introduced in 1960 to reduce the HIE, the hypoxic ischemic encephalopathy, but has actually been now done it? We don't know. It's still debatable, but it's definitely increased the interventions. every confidentiality report you look at it, it says there is an, the human element is involved, starting from the suboptimal care, mainly because of failure to interpret the CTG, and always not even just interpretation and failure to act on it. And of course, it goes without saying the medical legal issues involved in it. And if you look at it, it is just a sample. 9% of obstetric claims are made, but 50% of the payout is entire obstetric claims are 9%, but everything like 50% of the payment out goes to the obstetric claims. Where we do it, when we do it, simple thing, I just wanted to simplify it. These are the mothers. It's a term mothers, you have a mnemonic, and these are the terms, this is definitely we have to do it under these circumstances. There's so many ways of doing it. Mainly, these are the things which we have at the moment. I'm going to not talk about the individual in a detail, except CTG, of course, and a little bit about future, but I'm going to talk about salient points and where we commonly go wrong in one of this in this presentation. So, intermittent auscultation, I don't have to tell you, this is the time old and many people don't even know what PNAD is. But the important here is when we are doing it, we have to do it 15 minutes in the first stage and 5 minutes in the second stage, mainly because you don't want to miss a contraction. An acceleration sometimes follows a deceleration. That's what you don't want to miss it. So you have to be doing it. And another thing is you also need to do an escalation if you are not aware of, if you are not sure about it. In this case, just convert it to CTG. And another thing, important thing is many people have seen using this CTG the probe for using the intermittent auscultation, which is not correct. You look at the width of it, this can accidentally pick up the maternal pulse, and you think it's the baby's heartbeat, and things can change. So when we have a CTG, main point is we have a beautiful trace. This baby is telling us, look, I have acceleration. Accelerations are good. So my somatic nervous system is intact. I'm able to react to stress. I'm very happy. When there isn't good variability, baby is trying to tell you, look, my autonomic system is intact. I haven't, I'm mature, it's very mature, and there is absolutely no hypoxia here. That's the language you have to learn. Next thing is, when we have a normal trace, it's very likely to be normal indeed. That's the most important thing. And when you look at this is the standard stickers we use in our labor ward, where we have an white, amber, and red code. When you have contractions, everything is normal, it's normal. And if you look at it, variability is something which I want you to concentrate. If it is less than 5 beats per minute for 30 to 50 minutes, or more than 25 beats per minute for up to 10 minutes, it's falling under the amber category. If you look at the chart, it tells you one thing. First of all, you need to know why you are doing a CTG, not because you are bored or the mother is bored or somebody else is bored. We are doing it for a reason. And what is the baseline at the start of the CTG? For example, you do the CTG now, and then 1 hour later, somebody is saying, and they think it's still, the baseline is still within 160, but it would have gone from 110 to 160, which is a significant raise in the baseline. So always mention each point here is very important, and thus you make the baby, the interpartum monitoring safer. Also, you have to write a plan. It's just not about assessing. You also have to make a plan about what you're going to do and make a note of maternal pulse, and you have to sign it. And the idea of this fresh eyes is when you're doing it, even if it is normal, you have to make sure it is normal by asking somebody else, and that somebody else may or may not agree with your plan. So the chart says, if the person is agreeing with your plan, yes, it's all good. If they are not agreeing, they have every right to disagree with you, in which case you have to accept and then go for either, escalate it further or make a decision based on what consensual decision is. So another important thing is it's always tochocardiography, not cardiotocography. If you look at it, it's a beautiful baby, beautiful trace, very good accelerations, but suddenly you see something going wrong. But you also have a look at the contractions. The contractions are continuous. There is no relaxation in between. So if you look at it, the frequency, duration, intensity are all important. But the most important is it relaxing in between? That's a question you have to answer. At the same time, if you have tachysystole, don't panic. But you don't want contractions more than 5. But at the same time, if you have hyperstimulation, you have to panic, because if contractions are more than 5, but it's also making the baby to feel, the baby's heartbeat is not right. So immediately you have to act on it, which is commonly terbutaline is very safe, 250 micrograms subcutaneous. It's very, very safe. So if you have more than 5, just wait for 5, just wait and see, but don't wait till it becomes bad. Like in this case, don't wait, because this baby may not recover and may have it's a sign of acute hypoxia, which we'll look later. Then the baseline, I have said, it's very, very important. The most important point is if parasympathetic system matures at a later gestational age. So you are going to have a baby close to the term or post date with the baseline of 140. So if you are going to have a baby who is term plus 10, but the baseline is 160 beats per minute, think about sepsis. You cannot say it's just 160. It cannot be. It's something not right. You have a baby who's term plus 10, but the heartbeat is 160. This baby should have a parasympathetic system which is mature. So 160 is not right. So you have to rule out a temperature or hypoxia, which could be the other reason for tachycardia. So cycling is an important feature. I just want to show you some examples. It's a sign of fetal well-being. And you have, the only, if you have a trace like this, where the second one, where you have an accelerative phase and everything is fine, and then you have a cycling, you will not worry. But if it is the other way around, when you have a trace which is like absolutely no accelerations, no decelerations either, but going on for a long time, then you have to worry. In this case, you have to worry, but don't panic, because if you
Lata, Dr. Lata? Dr. Lata? Sahiti? Sahiti?
Yes, ma'am.
What happened, Dr. Lata? We have lost connection.
Yeah, ma'am has lost the connection, I guess, ma'am.
Ma'am told she was connecting from hotspot, right?
Yes, yes.
And do you want to reach her? Stop sharing, Lavanduttu.
She is logged out. She is logged out.
Shall I reach her? Anybody is trying to reach?
Yeah, I'm trying to call her, ma'am. நான் பார்த்துக்கிறேன்.
Madam, can you just send the request for video?
I can see, madam. Am I audible, madam?
Yes, sir.
Yes,
You're
ma'am.
audible, sir. Welcome, sir.
Sorry,
This is
madam.
Dr. Rajeshri. Welcome, sir.
Yes, ma'am.
We can see you, sir. Thank you.
Yeah. Have you started, madam?
Yes, sir. We are in.
We are
just
in progress, sir. Panel will take time, sir.
Yes,
Nitya, I spoke to Lata.
Yes, ma'am.
She's trying to connect. You have her presentation, right?
Yes, sir.
I'm having, ma'am,
Yes.
Sahiti.
Sahiti, you.
Yes, ma'am, I'll display, ma'am. I'll display that.
You share screen, you come to where she has come, do you know?
Okay. Yes, ma'am.
And she said if it's not possible, she will do the audio.
Okay, okay, ma'am, fine.
She's trying to connect. Lot of time.
Yes, ma'am.
Share screen, ma. Who is having her presentation?
Yeah,
Share
I'm
screen.
having, ma'am. I'll share.
Yeah, the next slide. Yeah. Yes,
CTG site.
this slide.
Yeah.
Yes.
Lata, yes. You're. Are you on mute, Lata? Sahiti, see, no, she's trying to connect to audio.
Can you hear me?
Yes, Lata.
Yes,
Yeah,
ma'am.
yeah. I'm so sorry. I'm so sorry. Okay, I'm
Okay.
sorry about it. So we'll carry on. So
Yes,
this is
thank
basically
you. Yeah.
you do cycling. Next slide, please. So accelerations is very important. It's said it's a hallmark of fetal well-being. But a baby with a good reserve, even that baby can undergo an insult. You cannot walk away saying that this baby is good and I can come back 1 hour later. No, because if you have a hyperstimulation or a hypotension related to the epidural or its thing, it can still undergo an insult. That's what is happening for the next slide. And then you have another situation where you have the decelerations. Decelerations, you actually divide into early, late, this same old category. But the important thing is the head compression and baroreceptor, carotid sinus, aortic arch stimulation leads to parasympathetic, and there is no intervention is required in this situation because there's no hypoxia. But if the decelerations are, you still have to watch out for it. That's the second part of the slide, where commonly you are going to see a variable decelerations, and this variable decelerations, if they are lasting, what are the concerning features? If they last for more than 60 seconds, if the variability is reduced, then it's worrying. If you look at the last trace, you have a deceleration, but it is also the variability is less. Next one. So this is the important slide, because if you look at it, the decelerations to the acidosis and death happens in a sequence. So if you have a deceleration, so it's the first one that's appear in case of hypoxia, but the next thing that happens is accelerations will disappear. So the baby is trying to talk to you here. Then comes the baseline heart rate. There is an increase in the baseline heart rate. And then comes, there is an compensated stress, where this stressful state is, baby is trying hard to keep the cerebral blood flow. There is an increase in the heart rate, the variability is normal, decelerations are becoming wider and deeper now. When it becomes decompensated, the baseline, there won't be any baseline because the baseline becomes unstable and the variability is also changes. Next comes the end stage where acidosis and acidosis can basically lead to fetal death. This is an important feature where you have decelerations for most of the time, where there is no baseline. We don't know whether it is an acceleration to deceleration or deceleration to acceleration. So this is a state of an subacute hypoxia, where there is a pH drop in every 2 to 3 minutes. So commonly it's because of the uterine hyperstimulation. As I said, oxytocin is the most used and most abused drug. You really have to be careful. If you are seeing the situation, if there's a hypertonus, stop the uterotonics and go for it. Change in the position. IV fluids is indicated only if it is, you have a problem where you have hypotension is identified or sepsis. Sorry, can I take 5 more minutes? Permission? Can I take 5 more minutes?
Yes, Dr. Lata, please carry on.
Okay. Yeah. Thank you. So, acute hypoxia. What happens in acute hypoxia? This is a beautiful slide. Single most important thing is you have a 3 minutes rule. If you have a deceleration, if it happens beyond 3 minutes, you have to act on it. You do something, you just, it's not normal. And then 6 minutes, if it's still not recovering, you have to shift the patient to in the first 3 minutes, what you do, you try to identify the problem. And if you can correct it. If it's identified, corrected, it's fine. If it's recovered, it will, come back to normal. It's just 3 minutes. But if it is not, next 6 minutes, you have to go to the theater. And then by 9th minute, if it's still the problem is not solved, then you go and deliver the baby within 12 to 15 minutes. This is a 3-minute rule. What happens, what are the things that can lead to acute hypoxia is these 3 accidents. When I say accident, it's not under your control or under my control. Anything can happen, as obstetrics is a dynamic situation. Cord prolapse, placental abruption, and uterine rupture. If it is iatrogenic, this is obviously iatrogenic, we are doing something, either, not intentionally, we either give the oxytocin as hyperstimulation, or we are giving an epidural, or some reason there is a hypotension, could even be sepsis. So this is a slide which tells you what can happen over minutes, and there's a well and truly a situation where you are fighting against the time. And the pH drops by 0.01 per minute every time. So chronic hypoxia shows off as a reduced variability. This is the baby who's telling you, look, I'm very tired, very sick. I just can't take up any stress. Even the smallest stress here, it is giving me a head. The next slide, please. Okay, sorry. Can you go to the previous slide? I was just talking about the previous slide. Yeah, this is an acute hypoxia. Sorry, I didn't show you the slide. 3-minute rule, 3 minutes, 6 minutes, 9 minutes, and so on. Next one. This is chronic, where you have the baby who's telling you, I'm not well, I'm very sick, don't stress me out too much. Next one, please. Okay, sinusoidal, we all know what it is. The most important thing is it's a sinusoidal. It's almost always abnormal, but you have to be careful about pseudosinusoidal, where there is a trace where you're trying to act by the time baby wakes up and then shows its well-being by accelerations and so on. So we really have to be careful before calling it as a true sinusoidal. Next one. Okay, this is an important point because many times you see a trace, there is a lot of gaps in the CTG trace. You cannot say whether there's actually a deceleration or what is happening. So in this situation, you run into the room, especially when you are monitoring the mother from a central system rather than being next to the mother. This is a problem. You go and rush to the room and mother will be sitting up for an epidural and then have this kind of a trace. So you have to be careful about the loss of trace, and if that happens, just put a fetal scalp electrode. This is safest thing to put it, and it just goes, and it's like a little screw type of thing, and it gets the head. But the most important thing is there are some contraindications for obvious reasons, like HIV, hepatitis C, and maternal. You can't do it. Next one. Next comes fetal blood sampling. It's almost digital scalp stimulation has replaced the FBS now, because we used to do before 2008, 9, 10. We used to do before doing every cesarean section, we used to do this to identify the pH, but it's totally gone now, because many people argue the blood you get it from the scalp is not the true representation of the baby's actual hypoxic or acidotic status. Next one. So really, this part is the newer development. Rajshri asked me to speak about the newer and the what we are going to have future. So this physiological criteria is coming up in a big way, and many units are taking up. When I showed you the trace about the normal suboptimal pathological trace, that is a criteria even NICE recommends, that's the current use. But the physiological criteria that focuses on avoidance of emergency operative delivery at no risk of intrapartum hypoxia. This is developed, and there's a wonderful handbook which I've given you. If you have time, you should all read this, where they say if you start interpreting the CTG by the traditional normal pathological and suboptimal, then you would end up, ultimately you will the perinatal morbidity and mortality may be the same, but you will be doing lot more interventions. When I say intervention, either obstetric delivery or a cesarean section, or that is something which will not happen if you use this physiological criteria. And this is a very good article. You can read about it. Next one. Computerized CTG. The topic given to me is intrapartum monitoring. But the problem with this is currently we are using computerized CTG, but unfortunately we don't use it during labor. That's the reason why I have not read this as, I shouldn't be talking about this now, but it's a good one to learn, because this is going to be the future. At the moment, we are not using it we are using it only during the antepartum, not during the labor. So these are the things which it looks at: baseline, acceleration, deceleration. STV is a very, very important thing, which is a short-term variability. I'll explain in a minute. These are the criteria it takes it. STV is actually a measure of beat-to-beat variation of the heart rate. This is expressed in milliseconds. The important thing is this is something which cannot be interpreted by human eye. So this is what the computer picks up. So it is not same as the variability what we see in our trace. This is something which is interpreted by the machine. So the next one. Next slide. So the STV, if you do it, the report will be like this. If you look at it, the STV is around 5 here. And this chart tells you if the STV is above short-term variability, is above, more than 3.0, then the risk of intrauterine death is almost 0. So based on the STV, you can kind of tell whether the baby is all right or not. Next one. Next slide. Okay. So what happens is, in this, but you can't use it while the woman is in labor, or even small contraction, it's not stratified. And another thing is, it is useful for patients like, where you bring them back once in 2 weeks, or a daily CTG if you have an abnormal Doppler or so. That's very useful. So what happens is, if you compare the computerized CTG with the traditional CTG, there is a reduction in the perinatal mortality with computerized CTG in the antenatal patients. There is definite evidence. So in UK, most of the unit recommend, and the early saving baby's life is recommended. The recommendations are given, and we use this for the antenatal CTG. So advantages over traditional CTG is it provides an objective assessment of the baby's heart rate, and the computerized CTG, it corrects the parameters analyzed by the gestational age. And important thing is very quick, and nurses or midwives can do it. And especially we don't have to make the patient wait for a couple of hours. Just do it, and if it meets the criteria, and they go home. So it includes the assessment of the short-term variation, which has been shown the best predictor of fetal well-being. Next one. So if you do a CTG, if you connect a woman to computerized CTG, you just don't go away straight away. You wait for 10 minutes. Obviously, computer is computer and human being is a human being. So if you have a woman who is bleeding heavily and so on, you just act on it. You don't wait for 10 minutes. But if 10 minutes, everything is fine and the trace is fine, then you leave it for 60 minutes and it tells you the criteria is met. If the criteria is met, then the hypoxia is unlikely at the moment. So they can go back to the original plan of weekly twice CTG or so. If there is a problem with the STV, which is less than 3.5, some units accept it as 3 or 3.5. If it is less than 3.5, then there is a risk of death or hypoxia is there already, and then you have to act on it. So this way, computerized CTG is superior in antenatal period, antenatal assessment of fetal well-being. Next one. So STAN is another way of analyzing the baby's heartbeat. What it does is this one basically is ST segment analysis. STAN stands for ST segment analysis. So interpretation and analysis of the fetal electrocardiogram is based on the ST segment. And it has a potential to reduce the neonatal metabolic acidosis. And there is a huge trial, but if you look at it with 40,000 numbers, so it's a very good N number, we look at it, there is no evidence that the use of this decision support software in conjunction with CTG reduce the likelihood of poor neonatal outcome. So at the moment, there is no evidence to support this. But these are the options we have at the moment. Next one. So what happens today in just 2 more slides, give me 2-3 minutes more, I'll finish it. So at the moment, what happens is if you admit a patient in the hospital, most of the units follow electronic medical records, EMR. Different hospitals use different software. But, if you enter a pulse of 115, it just escalates it automatic saying that it is tachycardia. If you put a blood pressure of 90 by 80 by 50, it automatically tells you it's hypotension, and automatically it tells it's called a MUSE score. MUSE is for early warning score, and maternity it's called a MUSE, where maternity early warning score. So this early warning score automatically escalates and tells the nurse, look, there is a problem with this patient. You have to take it to the clinician. So this is same like your HDU chart, what we use in ICU. But the thing is, HDU chart, somebody needs to look at it and escalate it. But here, the machine automatically alerts you, like, look, you have to inform somebody or do something. There is some MUSE warning is high. So this is the EMR. And this is what we are doing at the moment. If you apply the same principles to next one, if you apply the same principle, can you change the slide, please, for me? Yeah. So what is the advantage of EMR, electronic medical record, is you sit in a remote corner of the hospital and somebody wants a paracetamol, you can prescribe it online. And if somebody, the nursing care or midwifery care, it's augmented. They can do a better job because they don't have, sometimes 80-50, you are looking at 80-50 blood pressure. You don't realize it's a hypotension, but machine always picks up and tells you, look, there is a problem, please go ahead. So obviously it has got a better safety profile. The next slide. But it's not all good about, this kind of records. The same thing applies to CTG as well. CTG, if the machine interprets as an abnormal, is it really an abnormal? Are we going to agree with it? These are the challenges which we are facing with the current softwares. So at the moment, there is no accepted software for CTG interpretation during labor. That's the first challenge. Second is, if the medico-legally, what is the platform? Because we don't have any guideline to tell you, like, use this software, this is the best, this is time tested, this is done, N number was this is a randomized study. No, we don't have any evidence. Next one is, there must be a disagreement between the clinician and the AI. AI tells you, look, there is a problem, immediately do a cesarean section. We may not agree with that. So that is the second one. And then the conflict of interest may be a problem, because this conflict of interest will be very, very difficult to predict, because the cost and other things will be a problem. How do you pay, and whom is the ownership? That's a problem. Next is, For example, the best conflict is DNR, do not resuscitate decisions. I'm not talking about medical part of the CTG part of it, because these problems are involved in the regular medical care, and this is what we are facing day in, day out in electronic medical record. The same thing would apply. And think about maternity. Maternity is already a high profile profession, and it isn't like, the dynamic, all the risk factors. It's like walking on the rope in the peak, from one peak to another peak all the time. So with this variables at the moment, and another important thing is infrastructure. All units have to support it, everybody has to agree on it, and so on. And main thing is, most of the time people do defensive practice because of a fear of litigation and unnecessary intervention. And another issue is about resources. You have to provide a computer to every table, every bench, every place, and everybody should be able to log in, and they should be computer literate, everything. Next most important question is confidentiality. Sometimes when we are working, the patient can send you a message directly. Patient can send you a message. So what they see, previously we used to write a letter to the general practitioner. With now, what we write is sometimes patients are able to access and see their record, because confidentiality, ownership of the data is a problem. So with this background, getting an AI computerized CTG into the clinical practice is going to be a little difficult. I think the same thing, 20 years ago, we all, we never believed in Swiggy. We never thought we can buy a coffee with a Swiggy. But ultimately, we gave up our data, we gave up everything, and we accepted giving up our data. And finally, we are going to yield for this also, but it's just a question of when rather than how. Next slide. So this is an important, it's a very good article. What you wanted me to talk about, everything is there. And this is a the previous slide was a comprehension of this study. Next one. So with this, I would like to conclude. These are the studies I've kind of taken the, the information from, the papers from. So the important thing is, when it comes to AI to medical field, we are slowly yielding. Without our knowledge, we have done it so much. Somebody from US are able to give an opinion on a CT abdomen, whether it's an aneurysm or a bowel obstruction from somewhere else. So same should happen to us also, will happen to us. We are all going to yield and accept, but it's just question of when. And I don't have an answer at the moment. Sorry about it. Thank you for this opportunity. Thank you. And sorry for the technical fault I had. Thank you.
Thank you so much.
Thank you so much, ma'am. Thank you for this informative and a very interesting discussion. Our next upcoming session will focus on the WHO labor care guidelines, offering a comprehensive exploration of evidence-based practice. It is going to be a dialogue between Dr. Rajeshri ma'am, who is a consultant at Sri Swasthya Clinic, and Dr. V. Bharani. She is a member of Safe Motherhood Committee, OXI, and she's currently working at Sri Ramchandra Medical College. Over to you both.
Thank you.
Thank you, ma'am. I'll just share screen. Thank you. Right show.
Meanwhile, we request the audience to actively participate by posting your queries in the chat box. Our panel of experts are eager to answer any questions you may have regarding the topics discussed.
So before, good evening to all, we'll start this. Before starting, why a partogram? We are talking about evolution. So more than 1/3 of the maternal deaths, half of the stillbirths, and 1/4 of the newborn deaths occur due to complications during labor and delivery. That is, the intrapartum time is a major time which results in all these. So, and majority of these occur in low resource setting. So what is the need of the hour? The necessity is for an impactful, affordable, and cost-effective intrapartum strategy. That's where we were. And this led to the invention of partogram. That's how the partogram came. It's a gold standard labor monitoring tool to detect complications early in intrapartum and to intervene or to refer. We can take a choice of whether intervening or referring. That's how the partogram came. That's how we started partogram. And Bharani, can we have you talk about the evolution?
Certainly, ma'am. So, the famous African midwifery adage goes, the sun should never set twice on a laboring woman. This is what, because whenever sun sets twice on a laboring woman, we know we're going in for dangerous complications. So that's what led to a lot of studies. So Friedman's cervicograph, which was first introduced in 1954, was done by Friedman in African women. So he took 300 African women who delivered and he plotted the rate of cervical dilatation and he arrived at the sigmoid curve where he divided into a latent phase and an active phase, which had an acceleration phase, phase of maximum slope, deceleration phase, and then moving into second stage. So this he proposed to be a way of saying this is how cervical dilatation takes place in these women. And he suggested that the least 10% dilate the cervix at 1.2 centimeters per hour. This was Friedman's cervicograph. So Philippot was a man who was working in Harare, Zimbabwe, and he drew inspiration from Friedman's cervicograph. And he said, we need to introduce something called as an alert line and an action line in the partogram. So in 1972, Philippot and Castle introduced the alert line and action line starting at 3 centimeters. The alert line was to show the mean rate of progress of the slope in most of the patients, the slowest 10% of the patients. Now, both these people, the common feedback that people were getting after Friedman's cervicograph and as well as Philippot and Castle's alert line and action line was that they were talking about the slowest 10% of the people. That's what that was the 1 centimeter per hour rate that we always started speaking. So the WHO decided to do a composite partogram, drawing inspiration from both Friedgraf's cervicograph as well as from Philippot's alert line action line. So they introduced the composite partogram in 1994, which consists of a lot of components. Now this underwent a lot of modification. The modified partogram of WHO 2000 was the one that's commonly used, and we all continue to use it till the labor care guide was introduced. Now, along with just the alert line and action line, the modified partogram got rid of plotting the latent phase, and it said you start plotting the partogram from the active phase, and it also monitored the fetal heart rate. It also monitored the descent of the head, the oxytocin, the contraction, the intensity, the frequency of contraction, and a lot of maternal and fetal factors as well. For ease of use, this partogram was also color-coded, where whenever anything fell on the green part of the partogram, it is considered to be normal. Anything on the red part of the partogram was high alert, and anything in the amber is something where we need to either refer the patient to a higher center in case you're in a low resource setting, or you have to take a decision to deliver early. So this is how the partogram evolved through the ages. Ma'am, having spoken about the evolution of partogram through the ages, can you tell us how this partogram has actually impacted modern obstetrics?
Yes, Bharani. So what happened, there was an increase in stillbirth attendant from 2012 up to 2012, it was 69% stillbirth attendant involved in attending the delivery intrapartum. Worldwide, it increased to 81% from 2013 to 2018. So either they had a birth attendant or they were in the institution. And so it really became, and that started a reduction in the maternal mortality, perinatal mortality, and stillbirth, because labor was attended by a stillbirth attendant. There was a drop, and there was also a drop in reduction in the obstructed labor and VVF because of the monitoring, because of the use of partogram, and interventions were done. So people going in for obstructed labor and VVF was reduced, and the maternal mortality, the perinatal mortality, and the stillbirth rate came down. But what else happened was there was complaints from women because of the increase in numbers which the stillbirth attendant had to deal or the institution had to deal. The main thing was disrespect and abuse. There was no privacy. There was no birthing position choice. They were not being informed for a vaginal examination. Birth companions were not allowed. And there was no explanation for augmentation of labor, and people were also not given food and water during the process process of labor. Another thing was over-treatment, that is enema, perineal shaving for all, and then interventions such as early amniotomy, oxytocin for augmentation, and continuous fetal monitoring were used routinely for people. Also episiotomy. So this was another complaint. On the other end, there was under-treatment. Once they were institutionalized, there were deficiency in infection prevention by healthcare workers, deficiencies in hospital environmental hygiene, and use of unqualified attendants. So these were two things. On one side, yes, we were happy. People were getting deliveries attended by health attendant. But then because of the huge numbers, we had this complaint coming from mistreatment of women. So this led to increase in cesarean section rate. Worldwide, there was an increase in cesarean section rate, as you can see. And most of the cesarean sections, 50 to 80% of the cesarean sections were related to management of labor. That is, they fell either in Robson criteria 1, 2, or 5. So Robson criteria 1 was, as we all know, primary, greater than 37 weeks, and spontaneous, or whether it is induced in 2. So the rate that was advised by WHO was 10% for this Robson criteria 1, whereas it exceeded even more than 20 to 25%. So because of the active management of labor based on the partogram, there was increase in the cesarean section rate also. So this led to, that is, the over-medicalization and disrespectful care resulted in the raising cesarean section rate and also poor birth experiences for women worldwide. Yes, though it had a good side, it led to this also. And this led to the evolution of the WHO the curve, that labor curve graph that we are talking about. This was based on the emerging evidence of normal labor progression. So there is an individual variability of progress of labor, resulting in good perinatal outcome. It need not be 1 centimeter per minute or 1.5 per hour, or 1.5 centimeter. There can be an individual variability, and it did not affect the perinatal outcome. So the normal progression of labor was individualized. It can be different for different women, and 2, the global shift towards improving experience of birth. So this, following the 2018, the recommendation, intrapartum care for a positive childbirth experience, WHO did that, and this necessitated the design of a new labor monitoring tool called the WHO Labor Care Guide. This is how it led to the evolution of the Labor Care Guide. It contains, as you all know, Section 1, identifying information of the women and labor care characteristic at admission. Section 2 is the supportive care. Section 3 is well-being of the baby. Section 4, well-being of the woman. 5 is labor progress, 6 is medication, and 7 is shared decision making. So you have the identifying information and labor characteristic at admission added. The supportive care, which is for towards respectful maternity care. You have the well-being of the baby and women, and the labor progress is going to be different. We will go in detail about it. And there was also a shared decision making. So using the labor curve graph for managing labor and birth is now the WHO recommended standard for providing intrapartum care internationally. So this is towards positive childbirth experience and also reducing cesarean delivery rates. So the essential physical resources that are needed for respectful labor and childbirth care, emotional support from a companion of choice, effective communication by staff, pain relief strategies, regular labor monitoring, documentation of events, audit and feedback, oral fluid and food intake, mobility in labor and birth position of choice, pre-established referral plan, and continuity of care. So these were all included, and this was for the promotion of, this was the aim of the labor curve graph, is to promote women-centered care, stimulate practitioners to think critically around labor decision making, and individualize labor monitoring to the extent possible. So this is how it evolved. Bharani, can you now tell us the similarity between these and the WHO partograph, and also how it varies from the old composite graph or the modified graph?
Yeah. So we know that the partogram labor care guide both are giving us a pictorial representation. So a picture speaks 1,000 words. So we are going to have a graphical representation of the progress of labor, We are going to know when the membranes got ruptured, what is happening to the fetal heart rate, how is the amniotic fluid, is it clear, is there any meconium stained amniotic fluid, if there is any presence of molding or caput in the baby's head, what's the mother's pulse, BP, temperature, proteinuria, urine acetone. All of this is going to be marked in the labor care guide, just like it was being done in the modified photogram. We're also going to look at the duration and frequency of contractions. Something slightly different here is in the labor care guide, you don't have different shades. This like where we actually give dots for mild contractions, and then you give striped lines for moderate contractions, and good contractions are shaded dark. That sort of intensity of contraction is not marked in the labor care guide. Cervical dilatation is marked. Descent of the fetal head is marked. But when it comes to cervical dilatation, this is where there is going to be a bit of difference when you're going to mark the cervical dilatation. So we are going to say in labor care guide that the active phases become 5 centimeters now. What used to be 4 centimeters has become 5 centimeters now. And we've done away with the fixed 1 centimeter per hour alert line and an action line drawn 4 hours after that has been done away with. We're going to use evidence-based time for each centimeter of cervical dilatation. That is the most important change that has happened with the labor care guide. And the next very, very important thing is there's going to be an intensified monitoring of the second stage as well. Modified partogram, plotted the partogram till the woman got into second stage, and that's it. But here you're going to record the events in the second stage as well. And as we are speaking about a positive childbirth experience, we're going to have explicit recording of companionship, the pain relief the woman received, oral fluid intake, the posture she assumes during delivery. All of this is also taken into account. And of course, as I said, we're going to record the duration and frequency of uterine contraction, but not the strength of contraction. And very, very important point is you have the deviation from normal is being highlighted, and it is very easy for people to understand, easy for people to comprehend. Let us see how. The first, if we can move to the next slide now. So what happens when we took off the alert line and action line? We took it off because we said it does not account for the non-linear progress of each individual woman. Every woman will have a different progress of labor, and we cannot confine them by saying this is the alert line and action line. Rather than that, we're going to have a fixed rate limit over the first stage. If you can see what is there in labor care guide, we're going to see if the lady is going to be 5 centimeters dilated for more than 6 hours, then this is a critical value. So this is very easy for people, anybody to identify that if she's 5 centimeters for more than or equal to 6 hours, or if she's 6 centimeters more than or equal to 5 hours. It's very easy to plot. It's very easy to comprehend. It's very easy for decision making as well. So this is how we have now arrived at 95th centile of labor duration for each woman, and this is what is going to be plotted for the cervical dilatation. That's the reason why we've done away with the alert and action line. Second thing is the change to 5 centimeters for onset of action of labor. The ACOG in its safe prevention of primary cesarean delivery already told us the cervical dilatation should be considered 6 centimeters should be considered for active labor, because after this it is going to be standard for most people. That is what labor care guide is also trying to tell us. After a 5 to 6 centimeters cervical dilatation, the median range of cervical dilatation of about 0.8 to 1 centimeter per hour is going to be there for most women. So this is what we're going to say. Between the old partogram and now, the old partogram was taking the least 10% of the slowest rate of progression was what was being plotted before. But now we are going to take a median for people. So that is the reason why we have changed from 4 centimeter to 5 centimeter for plotting the partogram. Now, having discussed in detail about the modified partogram and the need to change the labor care guide, how are we using it? Are we really using it, ma'am? Is the utilization of the partogram labor care guide really that good?
Yeah, before going into the labor care guide, let us look at how the partograph was used. Because from 1972, like from when Philford said, the partograph was globally adopted, and it has been a part of the assessment of labor progress. It was recommended by WHO in the early 90s as a routine tool for displaying the progress of labor. But despite of it, the global acceptance utilization was only 31%, and correct completion rate was as low as 3% respectively. So the partograph as such, even the modified partograph of WHO, which was simple, was utilized only by 31% of people, and completion rate were as low as 3%. So what were the barriers? The barriers were looking to lack of provider knowledge and skills, time limitations. Yes, there is heavy workload. The nurses as well as the residents were not able to complete it. Inadequate equipment and supplies, and restrictive hospital policies. So the enabling factors were set: supportive and practical training for the skills, and also supervision by skilled people for regular and to give a regular feedback. The heavy workload, we'll have to have a teamwork to take care of the work, and we also have to be ensured that staff in the labor ward have access to the necessary resources and supplies to monitor and manage the women in labor. These were the enabling factors, as well as audit of the partograph in practice, including completion, decision-making, and referral of outcomes were recommended. So before introducing the labor curve graph, WHO took a usability, acceptability, feasibility of this labor care guide. This was an international study of 136 doctors, midwives, and nurses from 12 hospitals across 6 countries, which included India also. These doctors were trained to use the labor care guide. These hospitals had more than 1,000 births per year, with a minimum of 25 skilled health personnel working in the labor ward. And this was applied to 1,226 low-risk women. And 91.6% of women had a spontaneous vaginal birth. And there was an intrapartum stillbirth rate of 1.63 per 1,000 births. This was the study before even introducing, because the modified partograph was not being used, to see how useful this is going to be. And it had an acceptability. Initially, the practitioners found accepting a new tool challenging, but they became comfortable using LCG with practice. And they felt that the streamlined and coherent content in the single paper, it was in a single page, and they were very happy with that. But they felt that the layouts need to be larger. It was smaller squares that they had, and so they were not able to legibly put in the inputs. As regarding the utility, because it supported frequent, meticulous, and timely monitoring of women, and it guided in objective and data-driven decision-making. Because it was monitored, women were monitored meticulously, it guided in objective and data-driven decision-making, and it also reduced the unnecessary and early interventions because of the changes which have been made in the active phase as well as the intervention with each dilatation. So this had a positive impact on the quality of labor care and also on the health outcomes, including the C-section rate. And there was also, regarding the positive health experience, there was a person-centered, unique labor care that improved the doctor-patient relationship, and it also reduced the overall workload, because even though they had to do they'll have to enter these changes, but the overall workload reduced because there was a reduction in unnecessary and early interventions. This is about the utility. Regarding the feasibility, yes, the challenges in assessing the basic equipments and supplies such as thermometers, sphygmomanometers, they will have to check the urine acetone, the urine strips, watches, and Doppler were not available. So national or hospital policies relating to the physical layout of the labor wards, equipment and medical supplies, and standard protocols of labor care would need to be updated to provide an enabled environment. This was the recommendation. And this was particularly the case for supportive care, interventions requiring pain management protocol, where you had to give epidural analgesia, storage of analgesic, and physical arrangements to facilitate birth companions, because it was too crowded. Birth companions were not allowed inside. They didn't have enough space. It causes crowding. So these were the things that the hospital had to provide also. So WHO, before even introducing the labor curve graph, did the plan and then it introduced. Varuni, did it have any effect? What was the effect of this after introduction, the labor curve graph? How did it take over?
So the WHO, though they said it's going to be very feasible to do this and it's not going to be very difficult, there was a study published very recently in May 2022, a study done in India, where they tried to say that there's a shortage of manpower. The residents are overworked, the nursing staff are overworked. Staff, particularly in the primary facilities, especially if they're from rural areas, they were not skillful enough to evaluate for things like caput, molding, fetal position, as it is expected to be marked in the labor care guide. So they found it difficult to mark it in the labor care guide. And even access to basic equipments, like sometimes Doppler fetal monitors, urine analysis strips, all of these things were a little difficult in rural areas. So they were not able to do these recordings and enter in the labor care guide. Essential information like viral markers, blood group of the patient, all that was missing from the labor care guide. They felt that the space provided was too small and very difficult to mark it. And it was very difficult to scan and quickly interpret because there's no alert line, there's no action line, there's no color code. So it's little, you have to go and see and read and find out what exactly is happening. So that way, it was difficult to quickly scan and interpret. And this labor care guide, people said it was useful for low-risk pregnant women. But what about high-risk women who require additional monitoring, additional documentation? It was going to be very difficult to apply this on these women in a country like India. That's what this study, which was done in 2022, showed that it is going to be difficult to put this into use in India. But as ma'am said, considering the utilization of partogram itself is only 30%, and most postgraduates usually after the lady has delivered, the residents will go back and backtrace and write the partogram. Now, if we do away with that backtracing and chalking the partogram and start doing it, it's going to become easy. What do you say, ma'am?
Yes, Bharani. So that's why we will have to conclude saying that yes, we know that it has the potential to promote women-centered care and continuous assessment and decision making throughout labor. Yes, it is going to help. So it should be accompanied by the necessary initial and ongoing training, supportive supervision, and strategies to promote an enabling environment for practitioners. All these three, training has to be there, supervision has to be there, and it has to be an enabling environment, and also essential equipment should be made available, and updating facility policies on effective intrapartum interventions should also happen. Only then, yes, only after getting all these in process can we look at RCTs to see, yes, does the labor curve graph serve what it has come for? I think we have completed about the evolution and utilization. Bharani?
Yes, ma'am.
Thank you.
Thank you. Thank you so much.
Thank you so much, Dr. Rajshri, ma'am, and Dr. Bharani, for an enlightening discussion on WHO labor care guidelines. Our next talk will focus on the usefulness of intrapartum ultrasound usage in practice by Dr. Usharani, ma'am. Dr. Usharani, ma'am, is a professor and former HOD of obstetrics and gynecology from Sri Ramchandra Medical College, Chennai. Over to you, ma'am.
Thank you for the introduction, Nithya. Am I audible?
Yes, ma'am. Yes, ma'am.
Yeah. I think Rajshri and all of you have given me this topic of ultrasound once again.
Because you're
looking at pardon.
You're doing it, and we will want you to talk about it.
Yeah, sure. I will.
Thank you.
All of us do use certain amount of ultrasound in labor, or even for that matter, when you receive a patient, if you have the machine, you will see if you have a doubt in the presentation, placenta, fetal heart, if you have a doubt. And during delivery, in the second of a twin, if you have a doubt, all of us are using. Post-delivery, in the event, if you think there's any retained bit you want to check out, all of us are doing. What we have been trying to do is try to utilize the ultrasound in assessing the various, all the cardinal steps of labor. How can we actually make it objective? I think for the last almost 7-8 years, we've been trying to use it actively. Almost about 3 or 4 theses have gone in. So hopefully it will be useful for everyone who has not yet started to use it. I'll start sharing. My screen is visible?
Not yet, ma'am.
No, not yet.
Wait, okay. 1 second.
Ma'am, at first, please open the PPT, ma'am.
Pardon?
You open the
And then minimize it. And then click on share screen option in Zoom.
I've actually put the PPT on. It's on the usual mode. And I'm going back to
You have to
say
minimize it.
share.
Usha, you'll have to minimize and keep it down. Open the PPT, minimize it,
Okay.
and then that share screen
Yeah.
is there, no? Low down, green color.
Yeah, the share screen which வருது ஆனா அந்த ப்ளூ ஆக்டிவேட் ஆகல என்டையர் ஸ்கிரீன் and போடணுமா
இல்ல.
And then click on share. Click on share
share is
button.
not, share is not active. I'm just wondering why.
Ma'am, you will have to select on the ma'am. You will have to select on
Select
the.
the window, any window in that.
You will have to select on the window, ma'am, and then share.
I said it's send the window.
Then it will be activated. Share button will be activated.
Now,
Yes.
Correct.
Yes.
Yeah,
Now you will have to open your.
Can you see my see?
Yes, we can see your screen. You'll have to
PPT.
open the PowerPoint.
PowerPoint.
No, you have to open the PowerPoint.
Ma'am, we can't see your PowerPoint, ma'am. We are only seeing the share screen. Ma'am, just open the PowerPoint
See
presentation.
what happens, IT?
Ma'am has shared the screen option. So whatever it's there on ma'am's desktop, it will be visible to us.
Yeah,
So
below you
The
have
desktop
minimized.
is
now you need to open the PPT, ma'am. That's it. Only one step.
Yeah, I opened the PPT. I'm seeing my PPT and it says stop sharing.
Okay.
As if I'm already sharing.
Madam, we can do a short thing. Madam. You can send the who is doing this program. You can send the PowerPoint to that madam, so she can share and you can just tell.
Ma'am, stop share it, ma'am. So that again, while sharing, you need to select on
Yeah, I
PPT.
stopped sharing.
Yeah.
Now
I've
you go
stopped
back to share screen, and once
Screen
it
share,
opens, you open your PPT. Minimize whatever you've minimized. You just have to open it. Double click it and open it.
Yeah, I opened it.
Go after you share screen.
Okay.
Minimize it. Then share screen. Press on that share screen.
Yeah, share.
Clear. Now
Yes.
you have your minimized PPT there, no?
Yes, ma'am.
Yes,
Yes.
ma'am.
I've
Just
accessed
open that. Yes, ma'am.
Yes. Now make it slideshow.
You're able to see it?
Yes, ma'am. Yes, ma'am.
It's visible.
Yes.
Okay. So there we go. The older generation and she's and the share screen. Bunny must be laughing at me. Anyway, so that's it. Ultrasound in labor. This is how we are using it, transabdominal as well as transperineal. The aim of trying to say kindly use and get used to it, of course, we've been doing deliveries with our hands for generations, always. Even without obstetricians, there were deliveries. All my grandmothers and all delivered. But now, in order to make a safe vaginal delivery, more so when there's a difficulty, when you're thinking whether you need to do an instrument. Should I put an instrument? Should I do a C-section? And you feel, if at all I knew which is right, that is when this interpretation might be better. If you can practice ultrasound along with your clinical skills. So successful instrumental delivery sometimes becomes much safer than an emergency C-section, especially when you have a deeply impacted fetal head in the second stage, where you have increased maternal risk, hemorrhage, bladder injury, extension. All of us are very well versed with all the second stage complications when you do a C-section. And you have attempted a vacuum or a forceps and it failed, and now you go up and do a C-section. You know what kind of risks we all have faced, the difficulties, and so on. So, can we really avoid such a scenario? It will be a dream come true for every obstetrician if there's a tool which predicts the mode of delivery very accurately. So does ultrasound in labor really make it our magic wand? Let's go to a small case scenario. You've got a primary gravida, 39 weeks, low risk, estimated fetal weight 3.4 in active labor. Uterus is regularly contracting, and you have got a left spinal umbilical line. One pole is palpable, and we have come to the second stage. We're discussing only that. So the cervix has been fully dilated for an hour, membranes absent, clear like a vertex is at +1 station, and that's a caput 2+. And the left occipito anterior with a reducible molding, and pelvis is gynecoid. Half an hour later, that is 1.5 hours later after full dilatation and pushing, I should say pushing because now we are doing the labor care guidelines. So second stage starts with pushing. So late decelerations are noticed, and here you got a caput 3+. With all this caput, the suture lines are not clearly made out, and it looks like the station is at +1. So the decision for instrumental delivery has to be made, and the senior is called in to assess the pelvis to say. So the senior obstetrician opined that per abdomen one pole is still felt well, and she feels that the vertex is at -1 to 0, and there's a large caput. The hollow of the sacral bay is empty. So 1 hour 45 minutes since pushing and full dilatation with no scalp stimulation, persistent late deceleration, which are significant, and hence they said go ahead for a C-section. Now, suppose you don't have a second opinion. Can we ourselves look at any other modality? So, this patient was on a study on ultrasound in labor. The findings were transperineal scan was as follows. I'll just show you the pictures, and later on we go ahead to describe how the interpretation is done. So here we have this is a transperineal ultrasound, and this round thing is the symphysis pubis. Imagine you're having a sagittal section, and this is the head, this is the skull, and this little bump over there is the caput. So we find a large caput, and then we also find there is an overlap of the skull bones here. You find a good amount of molding, so both can be visualized in the ultrasound. And this we will discuss in later. This is the symphysis pubis. So you draw a 90-degree line down, and then you try to measure the distance, and we'll figure out how we are going to find the station using the transperineal ultrasound. And this once again is the sagittal with the symphysis pubis, and along the curve of Caris, this baby's head is still in the transverse limb. This is the descending limb, transverse limb, and as the curve of Caris, ascending limb when the baby delivers. This particular baby is still in the transverse limb. So this is, and then the lady section, of course. So here it is. We put the probe for the transabdominal like this, and the transperineal you put it on top. The pointer should be above, that is towards the anterior surface when you are doing a perineal ultrasound. So the use of intrapartum, transabdominal, and translabial ultrasound has been shown to objectively assess the relationship between the fetal head and the pelvis, and can indeed predict the likelihood of achieving a vaginal delivery. It solves two problems. It removes the subjectivity from the clinical assessment, and second, it can improve the clinical confidence, especially when you are trying to attempt an operative vaginal delivery. So trying once again to tell, one is the transverse plane, and one is the vertical. This is vertical plane, or the sagittal is what we put on the labia with the pointer upwards. This plane, the coronal plane, is used when we are trying to see the head perineal distance. So, what are all the things that we can see? A position, a station, rotation, asynclitism, caput, and molding. All can be visualized using your ultrasound. On the abdomen, you see the occiput and the fetal spine. So this is commonplace. Here you got the thalami, and you know that this arrow sign points towards the occiput. And if it is on the left side, you got a left occipital transverse. You put a probe and just above the symphysis pubis, and you find in occipital posterior, you will be able to see the nose and both the eyeballs staring at you, and you know you got an occipital posterior. So once again, showing how we are trying to see. This is actually a transperineal picture. You put the abdominal probe in this plane, in the coronal plane, and you will be beautifully able to identify the midline suture. Here is a left occipital anterior, 45-degree short of rotation. Sorry. So by putting the probe on the in this manner, if you put a probe in this manner, you'll be able to see this. We cover the probe using that hand care glove. Put a lot of jelly inside and put it in and hold it, and you'll be able to identify. So rotation can be very clearly identified, especially if you're planning to do any kind of an instrumentation. Degree of sharpness of rotation can be assessed nicely. You can also follow the spine along the transabdominally to see whether it is also rotated to a certain extent, but this is accurate because spine will not rotate and come anteroposteriorly, only the head neck will rotate and come. The importance of using this to identify the position is to pick up patients who have got persistent occipital posterior positions. Persistent occipital posterior is well-known cause of abnormal labor, as we all know. About 5% of deliveries, 20% at the onset, because most of them will rotate anteriorly. And we know that there's a higher, 13-fold higher rate of operative delivery, C-sections, when you have persistent OP. Occipital posterior position during labor mostly changes to the anterior position. Even all of us have seen on the perineum, full dilatation, it rotates. Nevertheless, most occipital posterior positions at delivery are the initial occiput posterior positions rather than a misrotation from an original occipital anterior or transverse. We are trying to say that a labor which starts with an occipital transverse or an anterior very rarely rotates posteriorly. It does happen, but it's very less. Whereas those which started with an occipital posterior, almost 80 to 90% rotate anteriorly and 10% tend to remain persistent OP. This is one more point that we would like to tell, that when the occiput is posterior and the spine is anterior, can it happen like this? Yes, because there can be some amount of rotation of the neck. The neck alone can go posterior, but the spine is at least lateral or anterior. Such babies, none of them will be born occipital posterior position. They'll rotate anteriorly and deliver. That's a very good feature that you can pick up on ultrasound. On the other hand, fetuses in whom both the occiput is posterior as well as the spine is also posterior. That is, spine of the baby is parallel to the spine of the mother. They tend to have troubles in the second stage of labor, and an ultrasound can give you a clue as to which of them is likely to rotate or not. Now we go to the station of the head. So all of us are very familiar, 0 plus 1 to plus 5. Now let me discuss this. If you look at this picture, the sagittal picture of a pelvic hip bone, and this is our symphysis pubis. This symphysis pubis is seen like this on the ultrasound beautifully. And here though you got the fetal head coming in, so you can't see the rest of the bones. But the ischial spine, this is our 0. If you drop a 90-degree from the lower end of the pubic symphysis, the ischial spine is 3 centimeters from it. That is, if you go to this picture, 3 centimeters from the inferior margin of the symphysis pubis is our 0. So from here you see what is the distance of this leading portion of the head. 1 centimeter is plus 1. So 1, 2, 3, maybe plus 3. Got it? So this is extremely predictive, and this can be done even when there's a huge caput. Very simple, just put a transperineal probe in a vertical plane and you can beautifully tell which station it is. And it has always correlated with the clinician station. We have done it over the last almost 7-8 years, and it is always correlated with the clinicians. Uh, the other simple method is this head perineal distance. We have to hold the probe in a coronal plane on the perineum in between the on the labia, a little pressure, and try to measure the distance between the head to the up topmost part, almost the skin. Anything less than 4 is good. More than 4 is a little less possibility. But all these things should be assessed progressively. You can't take just one and then say that's it. The head perineal distance is measured by calculating the shortest distance from the perineal skin surface to the outermost bony limit of the fetal skull in a transverse view. A shorter head perineum distance is significantly associated with shorter time to delivery and so on. So a head perineal distance of 3 centimeters or less at full dilatation favors a vaginal mode of delivery. So we saw the station, and this is also, head perineum is also trying to tell how low the head is. The previous one that we discussed here is quite good. It can be applied. Head perineum can also be applied. And another important thing is, this is the direction of the head in the curve of Caris. All of us have studied curve of Caris. Head enters like this. This once again being the symphysis pubis. So head enters like this, traverses transversely, and then goes up like that. So this is another very simple methodology. Just put a simple probe on the perineum with the pointer upwards, and you can beautifully see whether this baby in which phase of the curve of Caris it is. If you're trying to apply an instrument at this level, all of us know it will not come. It has not even started climbing into the. Here you got the baby nicely coming up, and it will definitely deliver. Even whatever instrument you put, it's going to deliver. So this is what we are trying to tell. The head baby in the curve of Caris, it goes like that. And the same thing can be beautifully seen in the transperineal ultrasound. This is something which I have always appreciated and always fell in love with. Considering the cardinal movement of the fetal head in the curved pathway of the pelvis, the concept of head direction is reasonable for assessing station. Horizontal or downward head is associated, definitely no. Even transverse, no. Only when it comes upwards we can do it. Plus 3 was the station when there was a upward. When you have an upward climb, the station is always almost plus 3. This is almost the same, except that you're trying to quantify the ascent or the change in the curve of Caris. The angle of progression is what was originally tried out. They called it angular progression. We had a small publication on this. The angle between the longitudinal axis. I can show you this. We get this image, and then you get the symphysis pubis and the head. So from here, you draw a line along the pubic symphysis, and from there you drop down, and it should touch the leading portion of the head, right? So this angle A is your angle of progression. It's very easy to imagine. As the head ascends along the curve of Caris, this angle obviously is going to become larger and more obtuse, isn't it? So this is the angle of progression. This is the picture that we took. This is the symphysis pubis. This is the symphysis pubis, nicely seen here. This is the leading portion of the baby's head, and the like small little caput there. So draw on your measurements. If you go to your ultrasound, click measurements, and you choose angle. You will get an angle there. So fix a cursor, draw it, and then bring it down, and you will be able to measure it will give, the machine itself will give it an angle. That's the angle of progression. Angular progression of 120 led to the probability of easy and successful vacuum delivery. In SRMC, when we did a study, we found our angle of more than 126 is equal to a successful vaginal delivery. Uh, the other thing that has also been seen as angle formed by the fetal occiput. See, here it is. The angle which is formed by the fetal occiput, and this is the spine. So a baby is like this, obviously it's massively deflexed, almost extended. So if this angle is acute, you know it is deflexed. If this angle is nicely bent, you know it is flexed. So that is called the flexion of the head or feto-occipital or cervical spine. Sorry, it's called occipitospinal angle. For this, you just need a transabdominal probe. We put the probe on the abdomen. This is how we need to put the probe on the abdomen. And you will easily picturize this. You'll easily picturize this. And this is how it will appear. This is the head. This is the spine. All of you can know that this angle is so obtuse. Whereas if you look at this, it's quite acute. Maybe 100 or 110. So it shows that the head is nicely flexing or not. So degree of fetal head deflection in the first stage of labor may be quantified accurately in a non-occipit posterior. Occipital posterior is a total different. You need to first master anterior, and then definitely you can also look at posterior flexion deflection by using a transabdominal ultrasound. Fetuses with an occipitospine angle of greater than 120, lesser than 125, that means the duration of labor will be increased. If it's greater than 125, it's well flexed, so it's going to deliver faster. Now we go to asynclitism. Asynclitism, and all you can easily pick it up after you see all this. Here you got an asynclitism. Is a feature wherein associated with occipital transverse position as a fetal head may tilt sidewards as it descends, with one parietal bone becoming the presenting part. The transverse fetal head position with anterior or posterior asynclitism is mainly caused by CPD. So as the fetal head is turned so that the posterior parietal bone presents, the sagittal suture is more anterior. It's called posterior asynclitism. Anterior asynclitism occurs when the anterior parietal bone comes down and the sagittal suture is shifted posteriorly. It can be easily detected sonographically by placing the ultrasonic beam at right angles to the midline echo. Now, this is a no asynclitism. That is absolutely perfect. So, if you have a posterior or an anterior asynclitism, you can see that this particular fontanella is shifted to one side, and hence you will be able to see one. If you look at this, you can see one orbit will be seen. One orbit you can make out here. See, one orbit is seen. That shows there is a tilt. There is an asynclitism, which is showing the orbit and not the usual typical biparietal plane. People have called it all these names and all. We're not going into it, and only for postgraduates. It's called the Malvasi side. North, that sun is setting on the northern side, sun is setting on the southern side to see if it is anterior or posterior. It's interesting, but that's how it has been described. If an eyeball is shown, then you know that it's probably not in the center. There is a tilt. Posterior asynclitism, you will see the eyeball on the opposite side here. Before I conclude, I thought I'll show you one putty video. I hope I'll be able to share my video. Can I just go ahead and open my video and say it will continue to share, is it?
Yes, ma'am. Yes, ma'am. It should.
It should. It should.
It's come out of share screen, no? She has to go share screen again.
Are you able to see anything?
Ma'am, you stopped share screen, ma'am.
Sharing the previous. Done.
You can minimize the video, share screen again, and then open the video.
I'll say stop share screen, cancel. That's what it says. cancel. Now stop sharing it.
Share screen.
Now I
Minimize,
say
minimize,
share
open your
screen.
video and minimize it first. Open your video and minimize it.
I minimized, Ray. I
Now you
opened
can
and
share screen.
minimized.
Share screen, ma'am.
I'll say share screen.
Yeah, now you
So you,
open the video.
Now
now I'll
open.
make this bigger.
Yes, ma'am. Yes,
Yes,
ma'am.
yes, yes,
Yes.
yes, yes, yes. You can.
Yeah,
That's
yeah.
all, huh? That
You can see the ascent of the
video is not playing.
it should play, you know.
Yeah, it's not playing.
It won't play like that.
It's playing. It's playing. It's playing. Yeah.
I'm pushing it forward.
Yeah, yeah. Because the center one, no, it is not playing. It is. That has to play.
Yeah, you can. I think it's playing.
Yes,
now.
yes.
Yes.
Can you make out here? This is the symphysis, and you can make out the head coming up nicely with each push. The baby's head is in the ascending limb of the curve. Just it's about +3. At this stage, you can definitely apply anything you want, much above also. So that is what I wanted to show for the day.
Thank you.
I'll stop. Yeah.
Yeah, you've stopped sharing. Thank you,
I'll
Dr.
stop sharing.
Thank you. Thank you so
Thank
much,
you.
ma'am. Thank you for this insightful session on the application and significance of intrapartum ultrasound and clinical practice. Our next segment will feature a distinguished panel discussing the strategies for addressing uncommon intrapartum complications. I welcome our moderators, Dr. Kartika Prabhu, Professor at SRM Medical College Hospital and Research Center, Katankolottu. Our next moderator is Dr. Maitreyi, is an associate professor at SRM, Katankolottu, Chennai. I would like to introduce the panelist, Dr. S. Nalina, Professor of Obstetrics and Gynecology at the Institute of Social Obstetrics and Government at Kasturba Gandhi Medical College, Triplicane. Dr. D. Narmada, the Senior Assistant Professor at ISO KGH, Madras Medical College. Dr. Padmapriya Vivek is a Chief Gynecologist, Obstetrician, Infertility Specialist, and Head of the Department at Global Health City, Perumbakkam. Next panelist.
Yes, ma'am. One second.
Dr. E. Shanti, Professor at Department of Obstetrics and Gynecology, Savita Medical College, Chennai.
Sorry.
Sahiti? Yeah. Yeah. And Dr. N. Bhaskar, Sir is a chief anesthetist at KGH MMC, and he is also the audit member of Tamil Nadu Maternal Death Audit. Over to the moderators.
Good evening, everyone. Thank you, Dr. Nitya, for your kind introduction. Firstly, I would like to thank the Safe Motherhood Committee Chair, Dr. Rajeshri ma'am, and Dr. Shanti Gunasingh ma'am for giving us the opportunity here. After listening to the recent updates in intrapartum monitoring by the eminent speakers, we now move on to the panel of uncommon intrapartum complications. So each pregnancy and delivery is different. So evidence also shows that complications around the time of labor and delivery are not easily predictable. Even though we do efficient antenatal risk screening, we cannot completely reduce the maternal and perinatal morbidity and mortality. So we require safe motherhood programs to enhance the strengthening of the emergency obstetric services. So we are going to now go on to the panel discussion on uncommon intrapartum complications. I welcome all the esteemed panelists for this session. So the first case was a 32-year-old primate gravida. She conceived after IVF. She was admitted at 36 weeks in spontaneous labor. She was normotensive. Her admission CTG was reactive. After admission, she ruptured membrane spontaneously, but perspective examination revealed leaking with dark red bleeding. CTG showed sinusoidal pattern, so she was planned for emergency LSCS. Dr. Shanti, what is your provisional diagnosis for this case?
First, I would like to thank the organizer for giving me this opportunity. And moving on to the case, have given me as she is a 32-year-old lady, conceived with IVF conception, and she is in labor, right? So on the CTG, which was reactive on admission, is now become sinusoidal. So the usual diagnosis, the common diagnosis, sinusoidal pattern after rupture of membranes. The common thing is to rule out abruptio of placenta. But she is normotensive. And the next thing to rule out is vasa previa. So sinusoidal pattern indicates fetal anemia. Here the acute anemia can be because of hemorrhage, which is because of either abruptio placenta or vasa previa, and placenta previa. Yes, but ultrasound has not mentioned, has not been mentioned. Yeah.
So normal CTG, when after ARM with bleeding and sinusoidal pattern, you should strongly suspect vasa previa. Dr. Shanti, can you just highlight about the other differential diagnosis for sinusoidal pattern in NST for the sake of undergraduate, postgraduates?
Yeah, very rarely, like if she is a case of like RH negative pregnancy, there can be a sinusoidal pattern, case of fetal maternal hemorrhage, sometimes cardiac anomalies, fetal cardiac anomalies, or it can be a part of a sleep cycle. So that is why the duration of sinusoidal pattern is important. Occasionally, there can be a spontaneous sinusoidal pattern, and sometimes suckling of the mouth of the fetus, no? So that can, so these two are physiological, but then it will not last for longer time. And sometimes, no, drug administration like narcotics can lead on to sinusoidal pattern.
So sinusoidal pattern also can be seen in twin-to-twin transfusion syndrome.
Yeah,
so this sinusoidal pattern, we have to strongly suspect severe fetal anemia.
Yeah.
Our patient delivered a live male baby weighing 2.3 kg with Apgar of 4 and 6. Baby was pale at birth and was shifted to NICU for neonatal care. Dr. Narmada, after delivery, the placenta was examined. Can you tell the diagnosis?
It shows velamentous insertion of cord.
So
maybe
can
the
you just
bleeding would have
explain?
been, yeah, usually what happens is the placenta, the cord actually comes mostly from the middle of the placenta and very rarely from the rim of the placenta. Now in this condition, it is attached to the membranes. So it's only through the membranes all the blood vessels converge and form the placental cord. So maybe in this case, probably when the membrane was ruptured, few of the blood vessels which have crossed from the placenta onto the cord would have got ruptured. And that's the reason for fetal anemia, because most of all the blood which comes through is, in this case, it's not antepartum from the mother, it is from the baby. So that is why the fetal sinusoidal pattern has appeared, because of the fetal anemia.
Yes, ma'am. This case, we have suspected vasa previa in labor. Dr. Nalina, can you just outline the management plan?
When we suspect vasa previa.
Ma'am, Dr. Nalina, ma'am, you are on mute.
Am I audible? Am I audible? I have unmuted already.
Yes, ma'am. Yes, ma'am.
When we suspect the vasa previa, the examination is going to be very rapid. So So the baby will go in for hypoxia and even stillbirth can occur. So delivery should never be delayed. An immediate crash cesarean section should be done. So on suspicion, we can do it. But antenatally, certain findings in the anamnese scan, which can be confirmed at a later period in third trimester scans, it can be confirmed. And it gives an idea to plan, admit the patient and plan delivery electively. So in this case, an immediate cesarean is to be done to prevent fetal catastrophe.
So whenever we are suspecting vasa previa in labor, so delivery should not be delayed. So because we are dealing here with fetal compromise. So in cases of sudden stillbirth in labor or whenever there is an acute fetal compromise during delivery, after delivery, we have to do a placental pathological examination to confirm the diagnosis of vasa previa.
When the patient is in early labor or in active labor, just before doing an ARM, it's a good practice to just feel the membranes to look for any dilated vessels which can be palpable. So that gives an idea whether vasa previa is there and makes us more cautious in dealing with the patient.
Yes, ma'am. Dr. Badnapriya is there?
Kartika, I think she is not there, I think.
Okay. Dr. Shanti, can any other way you can diagnose antenatally vasa previa?
So, yeah, by ultrasound, we can detect, we can diagnose vasa previa, but as a routine, we don't perform that. So in high-risk cases, probably whenever there are cases like low-lying placenta, placenta previa, or in case of twin pregnancy where the placenta is going to be a bigger one, and in case of accessory lobe, in suspected accessory lobe or suspensoriatal lobe, we can ask for or look for in the ultrasound for the vasa previa. Yeah. As a routine, I don't think we screen for thing. So, but in labor, we can diagnose vasa previa whenever we do a vaginal examination.
Okay, by ultrasound, how will you diagnose it?
So, ultrasound, whenever we suspect vasa previa, we use the color and the pulse wave Doppler. So, and when it shows a fetal arterial waveform, it confirms vasa previa.
Dr. Narmada, what is the recent screening guideline recommendation for vasa previa?
Actually, routine examination is not done as the previous speaker was telling. We don't routinely do the screening, but however, in conditions where you suspecting, we definitely look, and sometimes we look for a loop of cord around the neck, we accidentally come to a diagnosis. But now, like routine examination of placental cord insertion, if possible, and that too you have to do via transvaginal ultrasound. Then that time we can diagnose patients vasa previa, and we can give a probable probability rate or increase the suspicion of vasa previa. But I still really doubt that ultrasound will be able to 100% diagnose a vasa previa when we do not look at it the right way.
So according to ACOG guideline, so they advise routine examination of the placental cord insertion. So in our routine anomaly scan, we have to look for the placental cord insertion. In cases where we are who are high risk, who have second trimester low-lying placenta, we have to go for a transvaginal ultrasound with Doppler at 32 weeks. So as already the panelists have described the risk factors for vasa previa. So in these cases, we have to be cautious and screen antenatally and look for vasa previa. So because it is an avoidable obstetric tragedy, so we have to make every effort to detect vasa previa antenatally. Now I call upon Dr. Maitreyi to discuss about the next case.
Thank you, Kartika. Let us go to the next case. She was a 36 years, fourth gravida, para 3, living 3 with all previous normal vaginal deliveries with no comorbidities in this pregnancy. And she was admitted in our labor ward in active labor at 37 weeks, 6 days. On examination, all her vitals were normal. On para-abdominal examination, uterus was term size, contractions were there, and it was about 4 contractions in 10 minutes, each lasting for 30 seconds. Cephalic, average size baby, fetal heart rate was good, Liker was adequate. On parvaginal examination, os was 3 centimeter dilated, cervix 1 centimeter long, soft mid position, station -3, membranes were there, and there was show. Suddenly, she ruptured her membranes and during her contraction with a large gush of clear fluid from the vagina. That time, the woman reported an urge to push and then became confused. Next slide, Kartika. So on examination, she was unconscious, unarousable to painful stimuli, and on checking her vitals, she was hypotensive. Pulse rate was about 120 beats per minute. The saturation dropped to 86%. She was also tachypneic. On bilateral chest auscultation, there were crepitations, and per abdominal examination, uterus contractions were there. Fetal heart rate just dropped to 110 beats per minute. On PV, full dilated fetal head at the perineum. Next slide. So I would like to ask Nalina ma'am, what is the likely diagnosis and the differential diagnosis?
Here we have seen a multigravida who is in labor, who collapsed following the rupture of membrane. The collapse can be, first we have to look at the cause of collapse. Rather than looking at the cause of collapse, we have to resuscitate the patient. So we have to call for help and follow the ABCD, secure the airway, circulation and breathing, and then look for the disease, what disease it is. It can be either hemorrhagic or non-hemorrhagic. Hemorrhagic is very common, being a multigravida, but looking at the clinical features of sudden tachycardia and collapse, we can think about non-hemorrhagic cause, like most common being amniotic fluid embolism. So,
ma'am,
we have to keep in mind that grand multi, particularly anemic patient, going in for labor, and there can be an undiagnosed because of previous history of abortions and rigorous curator. There can be an acute rupture also. So, keeping the differentials in mind, we have to go about looking for it, stabilize the patient, and do a thorough clinical examination, look for the contractions, the contour, other things, and then do a vaginal examination and take care of the vitals.
Yeah, very correctly said, ma'am. Actually, when the patient is in collapse, definitely we have to first resuscitate the patient. But just wanted to ask you, like, what were the favoring factors for the diagnosis of amniotic fluid embolism?
Okay. Usually, the onset is very acute with usually the patient who is laboring who had a rupture of membrane or within half an hour of delivery, patient suddenly collapse. The sudden onset of collapse is very important. It's a very clinching thing. Patient becomes restless. She has acute chest pain, and a few cases we can notice a cyanosis. There are few cases who are presented with just DIC on presentation. The patient would have been normal, and suddenly she collapses and she starts bleeding. The uterus, which was firmly contracted, and the bleeding would have been under control. Suddenly, there is a PPH where the blood does not contract, and dark brownish fluid comes out to the os. So, sudden onset of collapse, and plus or minus around the time of rupture of membrane, particularly in a grand multi with the over-distended uterus, when there is a sudden gush of fluid, more likely to be an amniotic fluid embolism.
Yeah, ma'am, very correctly said. So when should we have an increased suspicion of amniotic fluid embolism? Can I just ask Dr. Narmada to please tell about if there is any criteria at all for this?
Yeah, one, there would be an acute hypotension for no reason or an immediate cardiac arrest. You don't even have time to respond to the code blue. Then comes acute hypoxia, and there is, with the onset of that, there's sudden bleeding from all sides, and she goes in for DIC immediately. So that would be like all of these like are within the peripartum period, like early peripartum period, or we have written as 30 minutes postpartum, with which we cannot explain due to any particular reason. So that would be the main for when you're really puzzled and you really are not able to come to a conclusion or think. So probably it is due to amniotic fluid embolism, which is such rapid onset and such rapid deterioration.
Yeah, very right, very right. Now I would like to ask Dr. Shanti, how are you going to manage this case?
Once we suspect amniotic fluid embolism, it is actually an obstetric emergency. If we don't attend to it immediately, keeping in mind the mortality rate can be as high as 80 to 90%. Okay, so immediate attention has to be paid. This resuscitation because amniotic fluid embolism is a clinical diagnosis. We don't have anything we don't have any time to diagnose. So immediately resuscitation should be started. So call for help, then start IV, 2 IV lines, and take the blood immediately, because we know that it is associated with DIC. So investigation has to be taken for that, and immediate delivery has to be planned. So whether they're based upon whether she is in full dilatation, is about to deliver, or immediately push her to cesarean. So meantime, resuscitation includes not only IV fluids and all the stuff, but the cardiac, we have the protocol, like she can go in for sudden cardiac arrest. So resuscitation, right? So pushing because it will be associated with hypotension, pushing the uterus towards one side, either left side or right side, depending upon the availability of the space. And immediate delivery is what is important, and take the help of, immediately call for anesthetist who can help in resuscitation, and immediate delivery is what is important.
Yeah, very correctly said. As the patient is in collapse, we have to think all these things at a time, and all should act hand in hand. Next slide, Kartika. Yeah, now as you told the role of anesthesiologist, so I would like to call upon Sir Bhaskar sir. So what are the actually difficulties in a CPR or resuscitation in a pregnant woman? How is it different from other adults?
Thank you, madam. Thanks for the opportunity. Actually, CPR in maternal cardiac arrest, almost every steps are same. The the physiology that happened because of gravid uterus pushing upon the pericardium, the site of compression will change. You have to go for the center of the chest. And the other thing, resuscitatory hysterotomy, the old name, that is, you have to go for a peripartum C section. This plays a very important role, because once you bring out the fetus, the compression over the great vessels is going to get reduced. You are going to have very good preload. And number two, the oxygen demand by the mother is also going to get reduced, because if it is going there, the resuscitation is for if you are going to have a cardiac resuscitation, it is you are going to do for both the mother and the fetus. Now, this is a scenario where we are trying to save the mother. Saving the mother is the first important one, rather than the fetus. So it is always emergency hysterotomy. You bring out the baby, you relieve the compression on the great vessel. That is going to give a very good impact, and the decision should be very quick. And the most important thing is this amniotic fluid embolism is a diagnosis of exclusion. So you have to go for your routine cardiac resuscitation, keeping in mind that it could be, as Dr. Nalna said, it could be any other reason. Even a myocardial infarction can also present like this, or a peripartum cardiomyopathy, which is totally undiagnosed, can present like this. All these things can come. So you have to just exclude everything, and you have to do blood investigation, which is other thing, and get what are things you call, if possible, call for a code blue, or the obstetrician themselves has to start with the cardiac compression.
Yes, sir, very correctly said. Actually, this is the time when we have to save the mother without thinking of the baby. So in labor room, such a situation happens now, we should jump upon we should not hesitate to do a CPR in this pregnant mother. And also we should not hesitate even to use the AED also. And definitely with the help of anesthetic team, we will do the other resuscitations. And I think the next slide. So, and there are some other measures which we can give. Next slide. So, sir, what are the basic investigations actually are warranted for this type of patients? We know that it is a diagnosis by clinical thing and not by of exclusion. So, but what are the basic investigation we should send? We should take this.
Basic investigation is routine hematocrit. There will be fall, and as such as the anesthetist, if you are having a GA, if the patient is on GA and the patient is going to meet out with an amniotic fluid embolism during delivery, they will have a sudden drop in EtCO2. That is one thing very clearly given. If the patient is under GA and suddenly the EtCO2 is cut off, then they have to be very alert that the patient has gone for something wrong. It could be a amniotic fluid embolism, or even venous air embolism. So these are things that can happen in GA. But otherwise, the thing is, you can go for hematocrit, this WBC counts, and coagulation profile. Chest X-ray will not be very clear. Probably the pulmonary artery bay may be enlarged, and ultrasound can pick up, focus can help in some way that the pulmonary artery pressure will rise up, and that is going to be very momentary. So the pulmonary embolism, that the amniotic fluid embolism that is going to happen, is going to be massive rush of the amniotic fluid into the right ventricle outflow tract, massive rush, and it will immediately dissipate. It will go into the peripheries of the lung. You cannot find out, but that initial insult that to the heart, when you are not identifying, when you are not resuscitated, it's going to cause some more complication. Even only you would have read in our pathology book that you can see the amniotic fluid within the alveoli. that is very tough. It is very rare and very tough to see. So the definite diagnosis for embolism is the pulmonary angiogram. This will take time. You cannot do this. So just as I already told, the amniotic fluid embolism is a diagnosis of exclusion. So you have to just immediately go for resuscitation. You just concentrate resuscitation. Try to save the mother. Give more importance to the mother rather than the baby.
Yes, sir. Yes, sir. Very right, sir. Next slide, Kartika. So, sir, what are your views about these newer strategies in the management? Are we doing routinely? Have you seen being done routinely in our daily clinical practice?
Very. This can be done in only very higher centerment, like ECMO. ECMO has its own complications. Not that easy to start an ECMO and as well to run it. But definitely, if the patient has gone for an ARDS, then one thing that can be tried is an ECMO. It might help. But to initiate an ECMO, to run the ECMO, it all depends on how much we are resuscitated earlier, whether there was a hypoxic insult. If there is going to be hypoxic, the patient is not showing any neurological recovery. So ECMO is also not going to help in the long run. At one time, the patient is going to go for a arrest or a cardiopulmonary bypass. All these things will take time. And like inhalation, nitric oxide, prostacyclin, these are more of more theoretical. It doesn't have any long, very big studies to support these things alone. Only thing is, as told by an earlier another team member, this is you identify early, concentrate in the resuscitation, try to bring the heart back to normal. You try to bring a sinus rhythm, try to maintain to get a control of the airway. These things will help the patient. If she is not having a hypoxic insult, definitely she will come out. But if she has gone for a hypoxic insult, then the things won't be in our favor. It has got the highest mortality, even the very best center throughout the world. But it's very rare, not that happening that much. Pulmonary amniotic fluid embolism, yes, it can happen. The things which we have to concentrate is when the raw area is exposed. You have to tell the anesthetist if the raw area is exposed and more bleeding, hypotension should be avoided. If a hypotension happens, the venous sinuses are going to be open to the air. So this can easily suck in the amniotic fluid or the venous air. If there is going to be large gush inside, this will immediately go and block the right ventricular outflow. So these are very practical things we have to manage.
So, Dr. Narmada, just can I ask you, like, this was a case where it was full dilate, she was in the second stage, but what about the delivery in some other cases?
Yeah, what we usually do is, the idea is, again, as Bhaskar sir rightly told, the idea is to save the mother first. So I would suggest delivery only in the only in the inside of a perimortem cesarean, because it is very difficult to resuscitate a term pregnant woman, and unless you otherwise the baby is delivered. So in that consent, in order to promote effective resuscitation of the mother, immediate on table or on the labor table itself, we have to do a perimortem cesarean section. That would be my first choice. And always in our labor ward, in our HTU settings, always a trash cart is kept ready with the materials necessary to do a perimortem cesarean section. So when there is an immediate arrest, as within 3 minutes, if you are not able to revive the patient, I think the 4th minute, the trash cart has to be pulled in and we start doing a perimortem section. And by 4 minutes, the baby must have been delivered in order to relieve the pressure and promote effective resuscitation of the mother. Because without delivering the baby, whatever amount of resuscitation we are going, it is not going to be effective at all. So first, relieve the weight of the baby, then only look up into the effective resuscitation part. Of course, we can always tackle postpartum hemorrhage in the backup of our blood banks and blood products available. But if you're going to use a golden period of initial 3 to 4 minutes, then it's very difficult to bring back the mother.
Yeah, very correctly said. If the CPR is not responding within 4 minutes, we have to go do it, and everything should be done within 5 minutes. So we have to be very, very active in this case. So in our case, actually, after resuscitation in the labor room itself, we did the delivery. We were lucky that she was in the advanced second stage, and we expedited the delivery by forceps and delivered a live male baby 3.2 kg with good upper score. Then the mother was immediately shifted to ICU, and other resuscitation with ventilatory support and the blood products were done with inotropes. Patient recovered and was discharged on 10th PND. Okay, over to you, Kartika, for the next case.
So the third case is a 26-year-old second gravida who presented to labor room at 37 weeks in labor. So antenatal period was uneventful. The senior obstetrician was occupied in OT. So the first year postgraduate was conducting the delivery. The patient had normal progress of labor and she delivered a male baby weighing 3.4 kg. While trying to deliver the placenta, the patient complained of severe abdominal pain. Patient became breathless, pale, tachycardic, and hypotensive. Along with the placenta, a pinkish globular mass was seen at the introitus with heavy bleeding. So immediately the postgraduate called her for help. So Dr. Shanti, as a senior obstetrician, what will you do next?
So considering the scenario, so immediately after delivery, right? So along with the placenta, there is a pinkish globular mass. So the probable diagnosis would be the inversion of uterus, the acute inversion of uterus. So as she rightly mentioned, she is called for help and immediately, okay, so it has to be replaced. So once the diagnosis is made, so if there is any doubt in the diagnosis, so clinical examination, the fundus will not be palpable per abdomen. And in case if there is any doubt, an ultrasound can be done to make out the fundus of the uterus. So our diagnosis would be acute
Dr. Nalina, how will you manage this patient when you are seeing a patient with hypotension?
So this scenario should not happen, which we have followed Amstel meticulously. Our juniors are trained in following the Amstel. And with control contraction, this is the least complication which can ever happen while we are following it properly after doing the oxytocin and control contraction. But still, the things occur. So any acute thing we have to call for help, as already told. So this patient goes in for neurogenic shock along with a little bit of hypotensive hemorrhagic shock. So the hemodynamic stability, airway should be secured. So if possible, give a bag mask, and as soon as the anesthetist comes, don't hesitate to intubate the patient. That is very important because it has more of neurological entity. And secure 2 IV line, as we 2 Gs, either gray or green Venflon should be given. And as you put the Venflon, take as much blood as possible for cross matching and for transfusion. And for other investigations, rushing fluid, crystalloids preferably, renal lactate or normal saline, at the fast rate of push at least 1 liter in 20 minutes. That should be the rapidity at which the fluid should be given. Give high flow nasal oxygen. And the best thing is, if you diagnose inversion, best thing will be immediate reposition. So the minute you diagnose, try to reposition after stabilizing as early as possible, after stabilizing the patient. So that is the risk of hemorrhage.
So we have to do both manual repositioning as well as hemodynamic stability should be maintained.
Transfusion should be ordered, and even MTP protocol should be activated. So there should be no delay in giving blood also. Once there is hypotension.
So we should try to do manual repositioning immediately, because once we make some delay, replacement will become difficult.
Yes. So immediately we have to try to.
So if immediate repositioning fails, what will be the next step, Dr. Narmada?
If the immediate repositioning stays, I would actually shift the patient to the theater. So because she need to be taken care of two ends, one at the head end to correct the hypotension, replace blood products if necessary in case she's going in for hemorrhage later on. And I need definitely some amount of anesthesia and for uterine relaxation. So as madam said, like if you give a GA, it is always better. You get every relaxed position. You can replace it as easily better. If not, tocolytic agents like magnesium sulfate or beta mimetic, but nothing works like a GA. The rest of the things, of course, we can always try in a low resource setting when you do not have a proper anesthesia team or you do not have a theater setup. You can try terbutaline at the local place on the labor table and try for manual repositioning then and there.
Dr. Bhaskar, sir, so for inhalation, what type of inhalational anesthetic agent you would prefer to use for this patient?
Actually, nowadays we are going more for TIVA, that is total intravenous anesthesia. In low resource setting, most of the machines, they don't have the volatile agent. Previously, they used to tell halothane will be the best, and nowadays halothane is out of vogue and very rarely available. And now good volatile agents like sevoflurane, CO-DES are available, but if it is not available, so even the relaxation that is needed to push back the uterus, that can be provided with very good IV agents. One of the best agents that is available, if you know how to handle the airway, the best agent that is available is the ketamine. So given the following the precautions for the drug, a short management of the airway, if you are having, even nowadays the difficult airway, they don't tell that you should go for an intubation. If you are having, because at least 3 to 4% of all the delivery, they have some difficult intubation scenario. So ideal thing is, if you are having an supraglottic airway like a LMA, you can manage the airway. You could just an IV anesthetic agents management with the ketamine, a good analgesia, either fentanyl, or even if you have the low resource setting, only fortpin, at least give fortpin and good sedation. That should give the, and if you are able to control the airway, put inside a tube, then you can go for a routine GA, use a neuromuscular blocker, a short acting blocker like atropurium, then give the relaxation that is needed to push back the uterus. So the best thing is, even if you don't have an volatile agent, you can just give the same plane of anesthesia for pushing back the uterus into the normal position with the IV agents also, and most of the drugs are even available at the low resource setting. So general anesthesia with a controlled airway will be the best one to happen. Or if there is a difficult airway, you are having have a difficulty in keeping the airway open, then you can go for a supraglottic airway device, and with some propofol and ketamine should do the trick. That it is very easy to do that. Have the baby has been delivered and everything, the things are under control. If you are going to have a airway control, the advantage is the hypoxic part of the resuscitation is taken care, and blood pressure control will be on your side, and there will be a severe vagal shock. To start with, definitely atropine or any agent has to be given, glycopyrrolate has to be given to the patient, and BP will be under control. Ketamine will increase the BP also, so it has a very good role to play here. So IV anesthesia can also be used to get a control of the airway, and as well as the resuscitation and the plane of anesthesia needed to push back the uterus inside.
Yes, sir. So after uterine relaxation, you should do manual repositioning. And once we have done manual, to stop the relaxing agents, and then start administrating uterotonic agents to prevent recurrence of the inversion. Then only we should attempt to remove the placenta. Dr. Nalina, can you just elaborate on how will you do the reposition of the uterine inversion?
Okay. The first thing to come is the fundus of the uterus in acute inversion. So that should be the last to be pushed out. So the last thing which comes is the sidewall of the thing. So usually we hold the fundus of the uterus like a U and start reducing from the side wall, from the cervical level up like that. We have to push on slowly to attain the thing. And once it is fully reduced, give a adequate uterine contraction and support so that again it does not come back, it does not recur. Sometimes we try to push back the fundus, and immediately on taking our hand out, there is a recurrence of the inversion. So we try it under anesthesia when manual reposition at the spot fails, or else we can even try a hydrostatic method where by gravity the saline is pushed under pressure, which helps in automatically pushing the fundus slowly up. So if all these things fail, next we go for the surgical option where the laparotomy. We can try to anchor through the round ligament, and slowly we have to pull step by step, like pulling the rope in a anchor. So the other thing what it can be done is when there is a constriction ring. In most of the cases which are neglected or which is occurred outside, and when they are transferred to a tertiary center, there is a constriction ring. So to handle it, we have to cut through the constriction ring posteriorly, vertically, and then try to reposition, and then once it is reduced, we have to resuture it. The thing is we have to cut the constriction ring. It can be done either open or by laparoscopic method, but these patients are mostly hemodynamically unstable. So laparoscopy is a challenge in those situations. So replace the fundus. Our book says vaginal approaches, but it is not done nowadays. It is obsolete nowadays because of certain risks.
So the thing is, first we have to try immediately. Once we diagnose uterine inversion, you have to reposition it immediately. If it is not possible in labor ward, you have to shift her to OT, and under anesthesia we have to reduce it. If that method fails, then you have to go for either hydrostatic method, and if that also fails, you have to go for surgical method, most probably laparotomy.
Very rarely hysterectomy also has been done when it has been for a long time. The tissues do not respond. So patient is hemodynamically stable. In that condition, it is very it is not that much feasible to do all these procedures. They have ended up in hysterectomy in few cases also.
Dr. Shanti, which cases you will anticipate uterine inversion?
So there are certain high risk factors where we can anticipate, like whenever it is a grand multipara, when you anticipate atonicity, okay, and whenever there is adherent placenta, okay, and most commonly it is because of mismanagement of the third stage labor, like as in this case, maybe like pulling, okay, pulling from below, and that which can be sometimes we see cases where fundal pressure are being given to deliver the baby. So excessive fundal pressure that is pushed from above, or inappropriate pull from below, or whenever it is associated with adherent placenta or precipitate labor, or sometimes it can be associated with short cord also. So immediately after delivery, there can be some traction in the fundus.
As rightly said, so we have to anticipate uterine inversion in certain cases. We should be cautious. So in our patient, manual repositioning was done under anesthesia successfully. The blood loss was 1000 ml and it was replaced with blood products. So the important take-home message is you have to wait for signs of placental separation. You should avoid a fundal pressure, that is Creed's method. Then you have to give controlled contraction for placental delivery. Even during cesarean, we should be patient and slowly deliver the placenta. The next case will be discussed by Dr. Maitreyi.
Thank you, Kartika. So let us go to the next case. That is a 25-year old patient, second gravida, previous cesarean section, was admitted at 39 weeks for delivery. And this was her first antenatal visit to our hospital. Emergency LSCS was done for her for the indication being the pathological admission CTG. So intraoperatively, actually, the placenta was found anterior and a part of it was adherent and could not be removed in toto. She started bleeding from the placental bed. So, Dr. Narmada, how are you going to proceed in this case?
First, whenever you come across such a situation, just call for help. So it is very heroic to manage alone, but it is correct to manage with help only. At the same time, you should alert the anesthetist team that you are having, you have encountered some issues during during the cesarean section. When you see such an amount of blood loss and you are not able to separate the placenta, first try to reduce the amount and then completely stop. When the uterine normally what we do for the regular postpartum hemorrhage, we start giving oxytocin, we start giving prostaglandins. At the same time, we should address the issue also. So first, I would go and ligate the uterine artery first. So that would be first, simple, easy. Within 30 to 45 seconds, we would have tied both uterine arteries. That would definitely and drastically reduce the amount of blood loss which is occurring within, like, say, like within a minute to almost 30 to 40%. Next, actually, we can decide whether we want to go for a radical one or we want to go for a conservative one. If the placenta is partially separated, at this point, I would try to remove the placenta and look into the placental blood. If it is totally adherent, I'm not able to remove the placenta, then I would leave the placenta in situ and proceed for a hysterectomy. Always when we do come across a situation, we remember hysterectomy always earlier, it is better. So decide for hysterectomy earlier than later and, putting the patient in trouble. So that would be my first line of thinking and management.
Yeah. So in our patient also, we did the same like hysterectomy because the PPH was not controlled medically and also surgical methods failed. So we went for hysterectomy for this patient. But in case your center is a low resource setting and you are not equipped well for the hysterectomy, then you can always consider the transfer to the patient in case the patient is stable enough. And with some temporizing maneuvers like packing the abdomen, tranexamic acid, and so on. So what is the role of expectant management? Suppose the patient is hemodynamically stable and the patient wants to conserve her uterus. So what are you going to do, Dr. Shanti?
So usually, whenever the patient, like in scenario where hysterectomy is not planned, there is a remote role of leaving behind the placenta, like tying out just the cord alone, but with the risk of infection and sometimes, a hemorrhage later on. So we need to keep in mind these things before we go ahead for this leaving behind. But this usually, we don't prefer, it is not a preferred method.
Yes. So what's the role of methotrexate in such a case when you leave behind the placenta?
So we know like methotrexate has, previously we were using methotrexate, but nowadays we don't advise methotrexate for it being associated with complications. So we always try to remove the placenta.
Yeah. So Nalini ma'am, can I just ask you, like intraoperatively you have opened the abdomen and you see a ballooned lower uterine segment with blood vessels on the uterine serosa. So how will you proceed in such a case?
Immediately on opening, if I happen to see such lease of vessels, so it should ring me the bell that the placenta is accreta or percreta, and I'm going to get into complication. I will alert the anesthetist, send for blood, start the transfusion protocol, ask for adequate blood. So I'll wait. If possible, I will try to wait for some more time till my team gets ready with it. And meanwhile, if there is any thing, then I would like to go through an incision over the upper uterine segment, preferably a vertical incision. So avoiding the leash of vessels. So I will try to delay and above the upper border of the placental leash of vessels, I will go deliver the baby as breathe. And immediately, I will try, because it is such vascular, I definitely expect adherence and percreta. So immediately, I will not try to remove the placenta, but instead try to talk to the patient after that, get a consent for hysterectomy. And in the meanwhile, give tranexamic acid, blood and blood products, adequate uterotonic drugs, and then gently I will see whether it is separating on its own. If not, directly I will proceed. In this such a picture is that I will try to go for a hysterectomy. With taking class.
Thank you, ma'am. Dr. Narmada, could you please outline what are the risk factors in which cases you will anticipate such a placenta accreta?
Any scars over the uterus previously, we have to keep placenta accreta in the mind. Now the event of the number of cesarean sections have recently been very high like of late, but now we are trying to bring down the cesarean sections for fear of these problems only. So any scars, especially when the number of cesarean sections increases in the same person, the chances of placenta accreta, percreta, increta, everything increases. The other less common would be the myomectomy, and repeated curettages or repeated abortions with instrumentation are also risk factors. Of course, there is traditional risk factors always, like smoking, elderly preemies, or multiparity, and recurrent miscarriage, where you can suspect placenta accreta. But whenever we come across a scarred uterus with an anterior placenta, I think we would do always an MRI near term to rule out any adherent placenta before taking the patient for surgery.
Yeah. Our case was actually accidentally diagnosed intraoperatively. So, Dr. Shanti, can we diagnose it preoperatively?
Yes, ma'am. Whenever we anticipate, see, that is what is important. Anticipation will help us to ask for, okay, when in a case of previous cesarean or any scars, we can ask for an ultrasound, which can detect, the accreta. So we have certain features like in our ultrasound, like that clear zone between the placenta and the myometrium may be lost, or the placenta, so that there can be loss of that bladder wall integrity will be lost, that is bladder wall interruption, or there will be myometrial thinning, the myometrial thickness is way less, and there can be abnormal placental lacunae. So whenever we anticipate this, always in case of accreta syndrome, we apply the Doppler. So in which gives additional information like the pattern of vascularity.
Next slide.
That is like utrovesical hypervascularity. Look for the placental lacunae feeder vessels. That gives a lot of information. So Doppler definitely helps in diagnosing the placenta accreta syndrome.
Yeah, any role of MRI, ma'am?
So initial screening, when we have, usually ultrasound is sufficient, but when we diagnose, when the ultrasound says that there is a placenta accreta syndrome, to plan for to know the extent of invasion of the placenta, we especially when in case of posterior placental accreta, we may not be able to diagnose in ultrasound. In that cases, when we have a doubt, we can go in for an MRI.
Yeah, very correctly said. So the take-home message should be, we should have always one attitude of screening the patients who are at risk of having this PAS, and on intraoperative identification, we should be very prompt in our decision of hysterectomy to save the mother's life. Thank you so much. Kartika, are we having any time for the next two?
No, due to time constraints, we will we will stop with this last case discussion. I and Dr. Maitreyi thank all the panelists for their very good, interactive, excellent opinions. Once again, I thank Dr. Rajeshri ma'am for giving us an opportunity to moderate this panel.
Thank you, ma'am, for giving.
Thank you, madam, for the opportunity. It was very nice. All the slides are very vivid and clear.
Thank you very much.
Thank you to all the panelists. Thank you so much. And thank you, Rajeshri ma'am and madam organizers who have given me the opportunity for being the moderator with Kartika. Thank you all.
Thank you so much.
Thank you very much for this opportunity. Love seeing you all. Bye.
Dr. Nitya?
Yes, ma'am.
Yeah.
Hello?
Yeah. We are done with our panel discussion.
Yes, ma'am. Sorry. Am I audible?
Nitya,
yes.
Yes, ma'am.
Nitya? Rajeshri?
Ma'am, yes, ma'am. Ma'am, am I audible? Yes, ma'am. Thank you, ma'am. Thank you for such a lovely panel discussion. I'm sure everybody has enjoyed listening to the panel. So as we conclude this webinar, I extend my heartfelt thanks to our Oxy President, Dr. Jairani ma'am, and our Oxy Secretary, Dr. Kundavi ma'am, and the whole Oxy team. My special thanks to the speakers, the participants, and the audience. Your valuable contributions have made this webinar very successful. My special thanks to Dr. Rajshri ma'am, our Safe Motherhood Committee chairperson, and the whole organizing team for their efforts. My heartfelt gratitude to our Shield Pharma for providing this platform, and sincere thanks to Chitrakala and Sahiti for always being there to help us organize it. Let the knowledge gained today inspire positive advancements in healthcare. Until we meet again, thank you and have a wonderful day.